Okay, so I'll sort of go again from here. So respiratory diseases, largest causes of death in the world. And basically they can affect any part of our lungs. So that could just be our lungs, our bronchi, our trachea, our throat. This could be nice and mild, starting with sort of basically a cold, and it could go up to something more life-threatening, such as tuberculosis, pneumonia, lung cancer. So it can be quite a big range. And one of the terms that we often hear a lot with respiratory diseases is COPD, which stands for chronic obstructive pulmonary disorder. And we often use the term as it being actual illness of its own, and it's not. It's actually an umbrella term for a group of diseases. And basically these group of diseases reduce airflow in the lungs, and they aren't fully reversible. So whilst you can improve someone's lung capacity, if they have COPD, we can't necessarily actually fully reverse them back to how they were originally. So we're going to look at two types of COPD today in particular. These are more serious types of COPD. So that's chronic bronchitis and emphysema, and both are usually caused by smoking. Lots of people can get, I don't really use the word normal, but normal bronchitis, so like viral bronchitis or bacterial bronchitis, quite regularly. Chronic bronchitis is slightly different, and that's often caused by smoking, and so is emphysema. So chronic bronchitis, we've got an image of the bronchi here. And chronic bronchitis is where the bronchi are narrowed. So this is a normal airway. Over here on the left, we've got good clear lumen, which will allow for good gas exchange and flow of air for inhalation and exhalation. Whereas on the right-hand side, we've got clearly inflamed airways. So the airways are narrowed, and then we've got a large amount of mucus. So chronic bronchitis is actually characterized by an individual having a persistent cough that produces phlegm. Why this happens is someone who's got bronchitis has increased number and size of goblet cells. So if you think back to when we were talking a little bit about goblet cells before, because we're talking about cystic fibrosis, goblet cells are those cells that have basically, let me draw on here. We've got those sort of cells that are sort of basically goblet shaped. They sort of look a bit like this, probably a bit more like that. And basically they produce mucus in the next to epithelial cells. So you can also get them in the lining of the stomach, small intestines, and the airways. And basically what happens with these is that someone who's got chronic bronchitis actually has an increased amount of goblet cells and an increased size of their goblet cells. So they're going to produce more mucus. So the airways of individuals who've got chronic bronchitis is going to have more mucus in them. That's going to reduce gas exchange in the lungs. And actually someone who's got an increased amount of mucus in their airways, when they cough, they're going to produce phlegm with that as well. Someone with chronic bronchitis also has a shortness of breath and wheezing. That's going to be due to those inflamed airways restricting that flow of air. But also the shortness of breath and wheezing is from the irritants in cigarette smoke. So we were saying earlier that chronic bronchitis is often associated with smoking. Cigarette smoke actually has a lot of chemicals in there that irritate the lining of the airway system. So these irritants can cause inflammation in the lining of the bronchioles, and that's how we get basically this inflamed airway that we can see on the right. But over time, this leads to scarring and a permanent narrowing of the bronchioles, which reduces airflow. So inflammation obviously is just a short-lived reaction, same as somebody who will get a reaction to any sort of irritant that goes into their body, anything that you sort of have an immune response to. So someone with hay fever, for example, you're going to have an inflammatory response. That's a normal immune system response to anything going into your body that seems like an irritant shouldn't be there. However, the more often that you smoke, the more often that these become inflamed, and then that can lead to scarring, which is basically like a permanent inflammation. It's like if you kept getting a ant's bite on the same place that you had an ant's bite, eventually that skin's going to start to scar. And because it scars, it actually leads to the narrowing of the bronchioles, this scarring of the inflammation. And so there's a permanent reduction in airflow. The other type of COPD that we're going to look at is emphysema. So, there we go. Emphysema is a gradual breakdown of the alveolar walls and damage to the terminal bronchioles and alveolar capillaries. So if we've got an image here. So basically, we're sort of talking now, chronic bronchitis is sort of the top of your lungs, that where you've got your bronchi splitting. Emphysema is working on the opposite end of your lungs, so your alveoli. Terminal bronchioles are the ones where they actually detach, I don't think that's the right word, but they attach, sorry, to the alveoli, actually to the lung lobes. So the terminal part is that end part of them, and then the alveolar capillaries, which are the capillaries that supply blood to the alveoli. If these alveoli walls get broken down, the terminal bronchioles get broken down, and the alveolar capillaries get damaged, basically we're just going to have a massive reduction in the efficiency of gas exchange. If this happens, this causes chronic breathlessness and hyperventilation. So on this image, we've got healthy lung tissue on the left and emphysema lung tissue on the right. And so we can sort of look at it and think, well, why is gas exchange less efficient in emphysema? Well, straight away, if we look at the left to the right, on the left, we've got a lot more alveolar capillaries. More capillaries we've got a larger surface area for gas exchange. We'll have a higher concentration gradient. So you can start to see that those reasons why. What is happening here? Oh yeah. So you can start to see those reasons why gas exchange becomes less efficient, because we've got less surface area for the gas exchange to occur. And so actually we're not going to be taking in as much oxygen as we really need. So how do we diagnose COPD? There's not actually one single test for COPD. That's also because COPD isn't just one illness, it's an umbrella term. So the diagnosis of COPD depends on the patient's risk factors. So whether that individual smokes, their age, also their symptoms and other clinical tests that have taken place. So some people can have COPD, but they might be completely different age and have different life risk factors. So we would test for different things. So we talked about spirometry before when we were talking about ventilation, and that tests the patient's lung function, and that's really essential. So that tells us whether there's any obstruction in their airways, and it also can help exclude the possibility of other respiratory diseases such as asthma or lung cancer, because at this part someone might just assume it's COPD, but actually it's asthma, or it might be something more serious like lung cancer. So spirometry really helps with that. So we're going to look now at how spirometry is used to diagnose the COPD. So we talked about before last week on how spirometry works, and we had a little look at the different values of tidal flows and peak flows. Now we're going to look at actually it specifically with COPD and how it works with COPD. So one spirometric test requires the patient to breathe in as deeply as possible, then blow into the spirometer as hard as possible until their lungs are empty. And then the patient's results are then compared with results that will be expected from a healthy person of the same age, gender, size, and ethnicity. So we look at the flow volume curve initially. So the rate of airflow should initially be high as air is forced out of the lungs. So we can see that here, we've got the airflow rate being high, and then slows as air is forced out of the smaller airways. So that is of our healthy person there. These are narrowed in COPD, so the rate actually drops off more quickly than in a healthy person, so that a flow volume from when we high airflow to low airflow is a huge decrease, a lot quicker in someone with COPD. So again, if you had a result looking like this, that would be indicative of someone who has COPD. Then we can look at the peak expiratory flow. So is the fastest rate at which a person can exhale air at the beginning of forced expiration. So in people with COPD, their PEF, which is their peak expiratory flow, which is up here, may be normal, or it could be reduced depending on the nature and severity of their condition. So again, this would be in a healthy person, that's in someone with COPD. But again, we couldn't use peak expiratory flow on its own because we've just said that it could be normal. It could be the same as a healthy person. So we have to look at other things with it. So if we look at the forced vital capacity, that's part at the end. This is the total volume of air that can be forcibly exhaled after maximum inspiration. A person with COPD actually generally has a normal FVC as the condition reduces airflow rather than lung volume. So if we were starting to actually see the volume, actually the FVC being lower than what we're expecting, that could actually be quite a good sign and indicator that actually it's not COPD that this person's suffering with. It could be something like asthma. It could be something like lung cancer, and that would be a sign that actually, okay, this person's got symptoms of COPD, but their forced vital capacity is of the normal healthy person. So what else could this suggest? We also look at the volume time curve. So in a person with COPD, the curve is shallower at the start and takes longer to plateau than the curve of the healthy person. So our volume time curve shows basically the volume of air that we're taking over a period of time. So it doesn't reach the same height as a healthy person, it's shallower, and it takes a lot longer to plateau than a healthy person. And that's because of the narrowing of the airways. So whilst we can take all these liters of air in, it takes someone longer because those airways are narrowed. So forced vital capacity, again, we're going to look at it on our volume time curve this time. So we looked at it on the flow volume curve. This time we're going to look at it on the volume time curve. So again, your forced vital capacity, as a recap, is a total volume of air that can forcibly be exhaled after maximum inspiration. A person with COPD will generally have a normal forced vital capacity, like we said before, as the condition reduces airflow rather than lung volume. So again, if this individual, whilst it might take them longer to get that forced vital capacity, they still reach that same volume. Again, if they weren't reaching that same volume of a normal healthy person, that could be signs that it could be another disease or illness. So forced expiratory volume after 1 second is something we'll look at with the volume time curve. So this is the volume of air that can be forcibly exhaled in 1 second. So a person with COPD will generally have a lower forced expiratory volume after 1 second than a healthy person. And that's because, like we were saying here, our airflow is being reduced rather than lung volume. So because the airflow is reduced, we can't get as much air out as quickly as a healthy person. And then we look at forced expiratory time in general, so how long it would take for an individual with COPD to exhale all of their air out of their body, out of their lungs. So a person with COPD will have a longer forced expiratory time than a healthy person because their constricted airways reduce flow. So then we can compare forced expiratory volume in 1 second to the forced expiratory volume in total. And that's this. So is the ratio of forced expiratory volume to forced vital capacity. So in a healthy adult, this should be about 75% to 80%. In a person with COPD, this value will be reduced. The more severe the COPD, the smaller value they will have. So how do we treat COPD? We've already said that it isn't necessarily something somebody can get actually wholly better from and restore their lungs back to initial pre-COPD capacity. But what can we do for treating COPD? So treating COPD, stop smoking is actually the single most important step in slowing down the decline in lung function in someone with COPD. And that's the main thing that the doctors would advise somebody who's got COPD, followed by some prescription drugs. So medicines commonly prescribed to treat COPD include bronchodilators, which widen our airways by relaxing smooth muscles. If we think we've got constricted airways in the bronchi, if you have chronic bronchitis, and we want to dilate them, so bronchodilators work for them, or corticosteroids, which act as an anti-inflammatory. You can also have oxygen therapy, and that's essential for people with emphysema. and that could be required for most of each day. So if we think about emphysema was damaging the lungs, the lining of the alveoli, the terminal bronchioles and the alveolar capillaries. So actually bronchodilators wouldn't necessarily have any benefit to someone with emphysema. Actually, they will probably just need to take in extra oxygen into their body because they're not, I want to say taking extra oxygen in more than what you just naturally breathe in because of the poor gas exchange that's happening. So you just have this constant extra supply. So your percentage of oxygen that you're breathing in is higher than a normal person's, but that can be required for the whole, most of each day. So asthma. Asthma is a chronic condition in which the airways occasionally narrow and become inflamed, limiting airflow. This is very different to something like COPD. So COPD, they've been damaged and they're permanent like this, whereas in asthma, they occasionally become narrow and become inflamed. It's why you have terms such as asthma attacks. So someone's asthma can flare up and become particularly bad, and it can be life-threatening in situations. So asthma is chronic, so it's long-lasting, but how much the airways are inflamed and narrowed can change over the course of hours, minutes, days, months. So asthma causes difficulty in breathing, wheezing and chest tightness, and can be mild to life-threatening. And asthma can be triggered by a huge range of stimuli for different people. So it can be things such as allergens, dust, exercise, stress, and infections. So things such as hay fever can trigger someone's asthma, pet hair, dust, increasing the amount of breathing during exercise, just being stressed, and then being ill as well. Treatment with bronchodilators or corticosteroids, or a combination of two, is the best way to treat asthma, because again, it's that narrowing of the airways, so it keeps those airways nice and open. People with asthma often get treated with two different types of inhalers, are often how people are treated with. So they'll often get a preventer, which is one that's like more of a milder dose. It keeps the airways open more wide than usual, and then they'll also have a reliever inhaler, and that will be one that when they become more tightened because of maybe a trigger, then that relieves and expands and dilates the airways even more, and then they can often be in the form of steroids. Also, some people with asthma will take steroid inhalers or steroid tablets as well. So lung cancer. Lung cancer is the biggest cause of cancer-related deaths in men, and the second biggest cause in women after breast cancer. And about 90% of cases are caused by smoking. So most incidences of lung cancer are due to uncontrolled growth of epithelial cells lining the airways. And cancers arising from these cells are called carcinomas. Symptoms include shortness of breath, coughing, including coughing up blood, and loss of weight. So you can see there how it could be quite easily in the beginning confused with COPD. And that's why doing those tests for COPD are really important, to make sure that we're not just saying to someone, oh, you've got COPD, when actually, in reality, they've got lung cancer, which we should be treating. Completely different there. So lung cancer generally develops very slowly, and by the time it's been diagnosed, the cancer may have spread to other areas of the body. When cancer spreads to other areas of the body, we call this a metastasis, and it makes it very difficult to treat successfully because we're trying to aim our treatment at lots of parts of the body, and can also then cause other damage to lots of parts of the body as well. Lung cancer can be seen on an X-ray or a CT scan, and diagnosis is usually confirmed after a small sample of tissue is taken, which is a biopsy. So a long needle would be inserted through chest, between the ribs, through the pleural cavity, into the lungs, and then aspirated. And we would take out a very small amount of tissue and analyse that. And like many other cancers, lung cancer is treated by surgery, chemotherapy, and or radiotherapy. So we're just going to have a look at some lung cancer statistics. So we'll look at incidence, mortality, and survival rates. So cancer incidence in males in the UK. The highest for males is prostate cancer. So this is incidence, not mortality. So the highest incidence rate is prostate cancer. Most men at some point in their life, if they get to a certain age, like we're talking about 70s, 80s, will have developed some form of prostate cancer. Prostate cancer is one that we actually just keep a check on. Some people have to have treatment for it, and some people have to have surgery, chemotherapy, radiotherapy. Lots of people also don't have to have any work done on it at all, and they can just leave it and just have it tested. So it's why it's very important that men have their prostates checked as they get older, because it is one that does occur a lot, but often doesn't necessarily also carry too much risk with it. But it is also important that it's checked early enough, because then treatment can happen nice and quick if we need to do anything for it. And that's why the incidence rate for prostate is very high. That's followed by lung cancer, then colorectal, bladder, stomach, NHL, esophagus, leukemia, skin melanoma, lip, mouth, pharynx, kidney, pancreas, brain, testes, multiple myeloma, larynx, and then Hodgkin's. In women, breast cancer is the highest amount. As you can see, the incidence rate, whilst it was still hugely larger for men, prostate to lung, the difference between lung and breast cancer in women is huge. Again, breast cancer is the largest amount of incidence in females. Again, followed then in very similar patterns then for women by colorectal. Obviously then the addition of, for women, you can have ovarian cancer, uterine cancer, skin melanomas, NHL, cervical cancers, pancreas, leukemia, stomach, bladder, esophagus, kidney, brain, lip, mouth, pharynx, multiple myeloma, and then Hodgkin's disease, and those last two be in the same position for both genders. So mortality. So we've got these in the same order of their incidence, but this time we're looking at the mortality rate for males. Like I said, prostate cancer, whilst it's the most common occurring in males, does not have as high a rate of mortality as lung. It does still have a high rate of mortality, and obviously that has a correlation with actually the incidence rate. That's followed by colorectal, then esophageal, stomach, pancreatic cancer, bladder, NHL, kidney, leukemia, kidney, lip, mouth, pharynx, multiple myeloma, and as you can see then the rest starting to peter off again. And then in women, actually has a slightly higher mortality rate than breast cancer, which is crazy when you look at how many women are diagnosed with breast cancer. So again, that's showing you how severe lung cancer and how much more aggressive lung cancer can be compared to breast cancer. So yeah, and then the others follow a very similar pattern. Colorectal, then ovarian cancer, which obviously doesn't occur in males, pancreas, NHL, esophageal, NHL, stomach, leukemia, follows those patterns. So survival rates. For men, prostate cancer's got a very high survival rate, whilst also having lung cancer has a very low survival rate after 5 years. It's actually got the second lowest, lowest being pancreas, followed by lung cancer, then esophageal, then stomach. Highest chance of survival after is testicular cancer, followed by Hodgkin's disease, skin melanoma, and then prostate. For women, it is the second lowest, again, survival. The lowest survival is pancreatic, followed by lung. The highest chance of survival for women is after skin melanoma, followed by Hodgkin's disease, breast cancer, uterine cancer, cervical cancer, 63, and then rectum, bladder, NHL. I've gone off order a bit there, but yeah. So is there a correlation between smoking and lung cancer? So there is a strong correlation between cigarette smoking and lung cancer, but it's just not necessarily imply causation. So we have to sort of look at what kind of evidence would convince you that there's a causal link between smoking and lung cancer. So smoking, so this is the amount of cigarettes smoked per year. And then if we add on lung cancer there, oh, is it not one both of them on? It's really annoying. Number of deaths. So obviously, as we can see, the amount of numbers of smoking has increased through the years. The amount of numbers of deaths from lung cancer has also increased over the years. So the first solid epidemiological evidence that smoking increased the risk of lung cancer came from a 1950 study by Richard Doll. He was a British doctor and epidemiologist, and Austin Bradford Hill, a British epidemiologist and statistician. And before their study, it wasn't clear whether the rapid rise in lung cancer was due to smoking or other atmospheric pollution, such as exhaust fumes, industrial plants, or tarmac, because they were all in huge increases at the same time. So their study of over 1,700 men and women in London concluded that the risk of developing the disease increases in proportion to the amount smoked. So it may be 50 times as great among those who smoke 25 or more cigarettes a day as non-smokers. So following Doll and Hill's research, there was a large-scale study into the health and smoking habits of British male doctors, and that began in 1950 and continued with periodic updates until 2001. Two of the main findings were long-life smokers died on average 10 years earlier than non-smokers, and the earlier smokers stop smoking, the more chance they have of avoiding reduced life expectancy. So if we look at this, which respiratory disease match diseases, their causes and symptoms. So we've got asthma, lung cancer, chronic bronchitis, and emphysema. So asthma, we've got reversible inflammation of bronchioles, breathlessness, and wheezing. So we would say that is asthma because that is reversible. It is inflammation of the bronchioles, breathlessness, and wheezing, but it is reversible. Lung cancer is an uncontrolled growth of epithelial cells, breathlessness, and coughing up blood. Chronic bronchitis is the inflammation of bronchi, breathlessness, persistent cough, induced and increased phlegm. And then finally, emphysema is the destruction of alveolar walls, breathlessness, and hyperventilation. So that is lung disease. The last bit we're going to look at on lungs is gas exchange in fish and insects. So this always seems a little bit random, but we do a lot about the gas exchange system in humans, and we actually have to know a little bit about it in fish and insects as well. So we're going to look at how gases exchange in fish and insects, the respiratory system of insects, and about gas exchange in fish and countercurrent flow. So we're going to look at insects first. So insects, straight away, we look at them and they are a lot smaller than us. So their surface area to volume ratio is very, very different. So insects have actually evolved mechanisms for gas exchange, and these mechanisms help them to conserve water. So along the outside of the insect's exoskeleton, they have tiny little pores, and they're called spiracles. And so basically this is like the insect's body surface here. So let's say it's an ant, and on the ant it would have a spiracle. Now to the naked eye we wouldn't be able to see this, but they have these tiny pores called a spiracle, and they are able to open and close. I guess in a similar way to a stomata, if you want to sort of link it to something in a similar way. But yes, the spiracle is able to open and close, and it's on the surface of their exoskeleton. Now, these spiracles, they lead to an internal network of tubes called trachea, in a very similar way to our trachea in our body. And their shape is maintained by reinforcing rings that spiral through the walls of the trachea. Again, you can start to see some similarities. Oops. The trachea then will branch off into tracheoles, and these fluid-filled ends of tracheoles attach here to muscle fibers. Okay. So respiratory gases move in and out of the tracheal system by something called mass transport, diffusion down a concentration gradient, and diffusion down a concentration gradient. So here we go. Here we've got a spiracle and we've got a grasshopper. So insects use something called a rhythmic abdominal movement, and that changes the volume of their bodies. It's able to flush air from one end of the body to the other, and this is called mass transport. So it's why, if we go back to this image, these tracheoles and fluid-filled ends of tracheoles are attached to muscle fibers. So basically, as the insects change the body volume in different areas, it will bring in more gas and volume to one area of the body, and then they make it smaller, it will then push that gas to another area of their body. And so rather than needing lungs to ventilate themselves, they can use their muscles to help ventilate and use this mass transport system. So spiracles, they have these air sacs that then basically inflate and deflate and move the gases along the body, and that is the mass transport. So that's mass transport. Diffusion. So cellular respiration reduces the concentration of oxygen and increases the concentration of carbon dioxide at the end of a tracheoles. Not surprising, that's obviously a different name, different area of our body, but that's the same idea. We reduce the amount of concentration of oxygen inside our bodies, increase the concentration of carbon dioxide. So this, in a similar way to our bodies, creates a concentration gradient, so that the oxygen diffuses from the atmosphere towards the cells, and carbon dioxide diffuses from the cells towards the atmosphere. And that is almost identical. Obviously, it's a different structure inside, but that actual diffusion is the same concept and basis that it would work in our bodies. So adapting to increased activity. So when insects are more active, their muscle cells produce lactate through anaerobic respiration, exactly the same as our body. However, this lactate lowers the water potential of their muscle cells. So water moves from the tracheoles to the muscle cells by osmosis. This decreases the volume of fluid in the tracheoles and draws air further into them, and this increases the rate of diffusion, allowing insects to obtain oxygen more rapidly. So that's really, really interesting. Okay, so when we increase our activity, our heart pumps blood around our body faster, we breathe faster and deep, more shallow but faster. In insects, they still go through anaerobic respiration like us, but they produce lactate. Lactate again, I'll repeat it, lowers the water potential of the muscle cells. So water moves from the tracheoles here, which is why they're fluid filled at the end. Water moves from tracheoles to the muscle cells by osmosis. This decreases the volume of fluid in the tracheoles and draws air further into them. This then will increase the rate of diffusion. So it increases that concentration gradient, allowing insects to obtain oxygen more rapidly. We also said that they are able to exchange gas in a way that helps them to conserve water. So as gases enter and leave the tracheoles through the spiracles on the body surface, a valve allows the spiracles to open and close. The spiracles are usually closed to limit water evaporation. So during periods of high activity, the spiracles are open to increase airflow into tracheoles. However, this does lead to greater water loss. So for most terrestrial insects, gas exchange is a compromise between obtaining enough oxygen and minimizing water loss through the spiracles. So here's an image of a spiracle there. So again, it's that play off. What do I need more of? Do I need more oxygen? Do I need to keep this water? I don't want to keep my spiracles open all the time because I'm going to dehydrate. However, if I keep them closed all the time, I'm not going to be able to take in any oxygen. I'm not going to be able to breathe. So fish. These are our next interesting ones to have a look at. Fish have evolved gills as an internal gas exchange surface, and they are found within the body of the fish behind the head. During ventilation, what happens is fish open and close their mouths to change the pressure of the buccal cavity, which is the space inside the mouth. So inside the mouth, they change their pressure when they open and close the mouth. What this does is this sucks water into the cavity and it forces it across the gills. So this is a bit of a better picture, our sort of picture of what gills are like. This is what's going to actually happen. So gills are composed of gill filaments, and these are all snapped together. And what happens is these gill filaments have lots and lots of protrusions, and they are positioned at right angles, and we call these gill lamellae. And they are used to increase surface area, which is probably not a surprise by now, as most of the answers in biology are often to increase surface area. So what happens is when water is taken in through the mouth, the water flows over the gills and then it exits through an opening on each side of the body, so through the gill covers. So they actually flows over the gills and then out through openings on each side of the body over here. So the flow of water over the gill lamellae and the flow of blood within them are in opposite directions, and we call this a counter current. So we've got the lamellae here, and we've got blood flow through the capillaries, and we've got our oxygen poor blood going through, and our oxygen rich blood going this way. So our blood is flowing in this direction, and our water is flowing in this direction. So they're going in the opposite way. Again, you can see it here. We've got our gill filaments, water flow running in opposite direction to blood flow. So blood going up and down, water's going the opposite way. So this is called a countercurrent flow. And what's really good is this maintains a concentration gradient across the lamella. Like we said before, maintaining that concentration gradient is really important so diffusion's happening all the time. If we're going in the same direction, it wouldn't be advantageous because we wouldn't have that change in concentration gradient, so diffusion will stop quite quickly. If they're flowing different directions, that means we've got a really, really steep concentration gradient being maintained at all times. So we're going to go through countercurrent principle in a bit more detail. So in fish, the flow of water over the gill lamellae, the flow of blood within them are in opposite directions, and this is called a countercurrent flow. So the benefits of countercurrent flow are understood by examining what happens when water and blood flow in the same direction. And this is a concurrent parallel flow. So that's when water and blood would flow in the same direction. So blood with low saturation of oxygen first meets water that is fully saturated with oxygen. So this means oxygen diffuses from the water into the blood. Did that just show that? I don't know, because I don't know when I paused that. As water flows alongside the blood, the oxygen saturation of the water decreases and the oxygen saturation of the blood increases. The concentration gradient is decreasing, but oxygen continues to diffuse from water to the blood. Diffusion continues until the water and the blood have reached an equal saturation of 50%. At this point, the equilibrium is reached and no further oxygen can diffuse from the water to the blood. So then it stops, diffusion doesn't carry on anymore. This means that a diffusion gradient is maintained for only half of the distance across the gill lamella. In concurrent flow, only 50% of the oxygen from the water diffuses into the blood, which is really not very advantageous, and it's just really not very effective at all, and it's not a great idea. It's why we use countercurrent. So in countercurrent flow, the blood and the water flow in opposite directions. This should stop that equilibria issue. So blood with a high saturation of oxygen meets water that is fully saturated with oxygen. So oxygen diffuses from the water to the blood, like it did before. Because the blood and water are flowing in the opposite directions, the amount of oxygen in the water is always slightly greater than that in the blood next to it. So this allows diffusion to continue and equilibrium to be avoided through the whole process, which is really, really clever. So as you can see, the numbers in water for the oxygen saturation is always slightly higher than in the blood. This means that countercurrent flow maintains a favourable concentration gradient between the blood and the water at all times, and we keep that optimum level. So over the entire width of the lamella, oxygen diffuses from the water to the blood. So insects have an internal network of tubes for gas exchange, and these are called trachea. Which of these is not a mechanism used by insects for gas exchange? They don't use countercurrent flow, they use mass transport, they use diffusion gradients, they reduce the waters in the tracheoles, they don't use countercurrent flow, that's only in fish. How do insects conserve water during gas exchange? Well, what they do is they close their spiracles so they don't lose any water. What is the function of gill lamellae in fish? It's not to protect the gills, it's not to regulate body temperature, it's not to change the water pressure in the buccal cavity, it's to increase the surface area of gills. In fish, the flow of water over the gill lamellae and the flow of blood within them are at right angles. In the fish, the flow of water of flow of blood is in opposite directions. What is the purpose of countercurrent flow during gas exchange in fish? It's not to allow fish to swim against the current, it's to maintain a favourable concentration gradient. Okay, so 10 minutes. Just going to have a quick look at the next bit. So it's circulatory system. We've done quite a bit of circulatory system before. We just need to have a quick look at a few bits that we haven't done yet. So surface area to volume ratio, we've talked about this quite a bit. So in large organisms, the fusion of substances would occur far too slowly to enable them to survive. So the rate of diffusion increases within the square of the distance it has to travel. So for example, basically insects can use the spiracles and the tracheal system for the gas exchange, but there is more diffusion occurring there than obviously in humans. This is not just because of size, however. More important, it's an organism's surface area to volume ratio. So single-celled organisms have a very large surface area to volume ratio because their diffusion path is so short. So, don't have a clue what's happening here. Let's move on from that. Okay, so components of circulatory systems. So multicellular animals overcome the limitations of fusion by having specialized circulatory systems. And these comprise a heart. So obviously we're talking about certain types of animals here. So, but yeah, a heart, a fluid in which substances are transported, vessels through which the fluid can flow. And the two types of circulatory systems are open, so in things like mollusks and arthropods, and closed, such as invertebrates and a few invertebrates. So the insects example I gave you was an open one, and closed is like the human and the fish one. So open circulatory systems, these consist of a heart that pumps a fluid called hemolymph through short vessels and into a large cavity called the hemocoel. So here we go, we've got a heart, and that pumps a fluid called hemolymph through short vessels, and it goes into this large cavity called the hemocoel. In the hemocoel, the hemolymph, which is that fluid, directly bathes organs and tissues, enabling the diffusion of a substance to take place. So we're just basically covering everything in this fluid, allowing that diffusion of substances to take place. When the heart relaxes, the hemolymph blood is then sucked back in via pores called ostia. And hemolymph moves around the hemocoel due to a movement of the organism. So it doesn't just sit in one place because the organism will be moving. Whereas in a closed circulatory system, such as in ourselves, blood is fully enclosed within blood vessels at all times. So from the heart, blood is pumped through a series of progressively smaller vessels. In the smallest vessels, capillaries, substances diffuse in and out of the blood and into cells. Blood then finally returns to the heart via a series of progressively larger vessels. So closed circulatory systems. So what are the difference? So we've got single circulatory systems and a double circulatory system. So in a single circulatory system, such as in fish, blood passes through a two-chambered heart just once in every complete circuit of the body. So we've talked about gas exchange in fish, but actually circulatory system in fish is a single circulatory system. And again, just to cover that, blood passes through this two-chambered heart here, so it's just got an atrium and ventricle, just once in every complete circuit of the body. So the ventricle, we have this deoxygenated blood. We've got gill capillaries here, blood becomes oxygenated. Here we've got oxygenated blood here. We've got body capillaries here, blood becomes deoxygenated, and then it goes back to the heart. So we've got this passing through surface. And we've got our double circulatory system. So in a double circulatory system, such as ourselves, and birds and other mammals, blood passes through a four-chambered heart twice in every complete circuit of the body. We've done a mammalian circulatory system a few times, but we've got a couple of minutes, so we're going to do a really super fast whiz through. So pulmonary circulation. The pulmonary circulation consists of all the vessels involved in transporting blood between the heart and the lungs. We then have systemic circulation, and that consists of all the vessels involved in transporting blood between the heart and the body, but excludes the lungs. So capillaries of the head, neck, and forelimbs are up here. We have the aorta, pulmonary arteries, capillaries of our left lung, capillaries, of the right lung, capillaries of other organisms such as kidneys and gonads and lower limbs. We have our inferior vena cava and our superior vena cava. So remember, vena cava is made up of two blood vessels. We have our right pulmonary vein, left pulmonary vein, hepatic vein, capillaries of the liver, hepatic portal vein, capillaries of the digestive system, gastric and mesenteric arteries, and then hepatic artery, and then the heart. So all arteries contain oxygenated blood. That is false. Remember, our pulmonary artery does not contain oxygenated blood. All veins lead into the heart. That is true. Systemic circulation transports blood between the heart and lungs. That is false, because that would be pulmonary. In a double circulatory system, blood flows through the heart twice in every complete circuit of the body. That is true. Birds have a single circulatory system. That is false. And that is that for today's. Let me stop recording, stop share.